I've spent my adult life in the field of global health. My work has taken me from the shanty towns of urban Haiti to the hills of post-genocide Rwanda, and now to the melting seas of the Arctic. I've seen the ways the poor live and die in a world defined by inequity. But today, I want to talk to you about the ways the poor live and die here in the United States, and why I believe it's time to bring global health home. I came home to the US at an auspicious moment for global health. I had spent several years working on health systems reconstruction in Rwanda, and everywhere there were signs of progress. My return coincided with the final year of the Millennium Development Goals, an ambitious framework to improve health and well-being globally. Under the goals, maternal and child mortality were halved, and Rwanda registered some of the most dramatic gains. Life expectancy increased significantly, and extreme poverty was halved. Against the backdrop of this global progress, I encountered a very different situation here in the United States. For the first time since the height of the AIDS epidemic, life expectancy fell in 2015, and then in 2016. Researchers looking at this alarming trend found surging death rates in poor, uneducated white Americans, even as racial disparities in life expectancy finally narrowed. The causes of these deaths are not those that you might expect: heart disease, obesity, diabetes. Instead, these are deaths of despair caused by suicide, alcohol and drug-related overdoses, and alcohol-related liver disease. And these rising death rates reflect declining overall health, with nearly 80% of low-income Americans experiencing poor health. Today, we speak from the epicenter of this crisis. In 2015, New Hampshire led the nation in fentanyl-related overdose deaths. Vermont was 10th. I've spent a lot of time trying to reconcile the converging patterns we see globally with the divergent trends at home. What does global health have to say to these challenges? What does a movement that's focused on closing gaps in access to essential medicines in low and middle income countries have to offer a crisis of overuse of prescription drugs in our own context? As I've contemplated this question, I've returned to my own roots in global health. I've had to re-examine my response to a common question: how did you come to this field? I usually explain that I began as a young human rights worker in Haiti. There, I witnessed victims of human rights violations survive physical violence only to die from a lack of access to health care. I wanted to spend my life fulfilling the right to health rather than cataloging abuses against the right to life. But I came to TEDx today to have a frank conversation with you, and I'm going to start by being honest with myself. I went to global health because it was easier to fight for access to healthcare globally than to engage in the struggle for equity at home. Early on, I saw the ways in which what Paul Farmer has described as structural violence, or the violence that's embedded in the social and political arrangements of our world, is reenacted in other forms of violence. I saw claims for justice from marginalized communities framed in language that appeared incompatible with the polite discourse of human rights. I saw survivors of human rights violations perpetrate violence against other survivors. Global health represented an area of moral clarity in a world blinded by injustice. And if I'm being honest with you today, this work didn't begin in Haiti, but started much closer to home. Just over 15 years ago, I was a student at Dartmouth interning with an organization providing legal services to women in rural Vermont. As I drove westward into central Vermont each morning, I would encounter the Takeback Vermont signs peppering Vermont's bucolic landscape. That summer, Vermont would become the first state to legalize same-sex civil unions, and Vermonters, or natives of the states, had painted barn walls and erected signs in protest. As a native of the blue-collar Midwestern suburbs, homophobic sentiment was not new to me. However, these makeshift notes of protest awakened me to a struggle extending far beyond a contested piece of legislation. On the surface, these signs were a rejoinder to a social policy anathema to Vermonters and to the flatlanders or urban liberals promoting them. I now know that I went to work in human rights internationally because I wanted to join a human rights movement at the vanguard of social change, rather than one resisting efforts to reclaim the past. Takeback Vermont, I now recognize, though, was not an expression of nostalgia for a fading pastoral era, but rather a cry not to be left behind in a rapidly globalizing world. Beneath these signs lay the pains of shrinking opportunities and loss of rural identity in a changing global economy. When I returned to Vermont, I saw roots of the current crisis in the Takeback Vermont movement. Opioids had moved into many of the communities I had visited many years earlier, and Make America Great signs stood on hills previously occupied by those from Takeback Vermont. As someone who's worked for many years to improve health systems globally, I've been encouraged by calls to bring practices from global health, such as the use of community health workers and mobile health technologies, to bear on these problems we see in rural communities here. I'm reminded, though, of what I saw as the failure of traditional women's organizations to make inroads in addressing the prevalence of domestic violence in poor rural communities. Rural geography and poverty intensified the physical, cultural, and social isolation of women experiencing abuse. More importantly, though, many women identified more with their husbands, partners, and extended family than with the organizations led by Flatlanders. Indeed, so many women desperately seeking to escape violence identify themselves with the Takeback Vermont movement. Certainly, we can learn much from successes elsewhere. However, I fear that our persistent desire to import healthcare innovations from abroad points to a persistent desire to avoid grappling with the underlying inequities that produce both poor health and political grievances that we see represented in the Takeback Vermont and now Make America Great movements. A growing body of research now attributes the plummeting health outcomes we see not to a lack of access to healthcare, but rather to growing financial insecurity, financial strain, and feelings of exclusion. Stress related to economic insecurity may have particularly great effects on the health of the poor, particularly because it's perceived as outside of their control. And even as economic well-being improves in many communities, these gains are weakest in rural areas. In this misplaced search for solutions to a problem that's become a bellwether for the health of the Republic, I think we've forgotten that it was never new technology or interventions that propelled the successes we see globally. You see, when I came into the global health movement at a moment when the dominant perspective was still that some lives mattered and were worth saving and others simply weren't. AIDS threatened to decimate entire countries, even though this was several years after highly effective antiretroviral therapy had become available here in the US and other high-income settings. Vast parts of the world were seen as too backward to benefit from modern medical technologies. Cultural practices and traditional beliefs, many reflecting a lack of access to basic healthcare, education, and other rights, were advanced as a premise for denying access to treatment. Marginalized communities hardest hit by this epidemic, the gay community, sex workers, migrant populations, intravenous drug users, were seen as dispensable. This pernicious racism and discrimination resulted in a lot of stupid deaths. I see echoes of it in our view of struggling communities today. The global health movement emerged out of rejection of this notion that we inhabit three worlds, not one. At its core is a belief that health constitutes an inviolable human right. Scientists, activists, civil servants, patients, communities, and college students, much like yourselves, came together to battle for access to these drugs and then for the systems needed to deliver them. Those of us on the front line of rebuilding these systems knew that the stakes went far beyond stopping preventable deaths in our local catchment areas. We had to demonstrate proof of concept, and that concept was that the health of the poor was worth investing in. Today, 18 million people are alive thanks to HIV treatment, and the tide has turned from a discussion of whether to treat HIV in poor settings to how to address a broader range of disease priorities to how to achieve the once unthinkable goal of universal health coverage. Today's ever-expanding global health agenda now includes non-communicable diseases, injuries, and cancer. Our concerns have shifted too, from utter neglect of the diseases of poverty to cluttered landscapes, equitable partnerships, and the appropriate use of technology. But let us recognize that global health has always been a movement to recognize our common humanity. Certainly, we need modern medicine to realize health is a universal right. However, this is merely how we operationalize this right. And it's this affirmation of dignity that is so urgently at stake in communities dying from despair. I'm here at TEDx today because I believe it's time to bring this global health movement home. But as we turn the moral compass at the heart of global health homeward, we need to shift the global health paradigm from one focused on access to one built on the imperative of equity. Today's epidemic of despair has emerged along the very fissures from which we collectively averted our gazes, and we need a new agenda to transcend these divides. I'm sure you're asking, what does it mean to build a global health equity agenda? Equity, the idea that all humans have the potential to realize their optimal health, requires us to look at the broader conditions necessary for health. An agenda for access begins at the healthcare system, often at the point of illness. It asks, what are the gaps in healthcare services, and often assumes that we can fill them simply by an exchange of commodities or knowledge from higher to lower income settings. An agenda for equity begins in the communities bearing the burden of poor health. It asks a very different set of questions. What do you need to be healthy? What is your vision for your health? How can we work together to achieve this vision? More importantly, though, an agenda for access presumes that we inhabit different spaces and time. An agenda for equity recognizes our interdependence. It requires us to think about marginalization, lack of social and economic power, and the institutional arrangements that govern our world, not as a means to delivering a medical intervention, but rather as the basis for a healthy life. And this, in turn, gives us something more important. It creates the basis for solidarity and begins to heal the divides that drive despair. But I think the real question you're asking is, why should we, the most global generation ever, care about communities much closer to home, especially when their social beliefs and voting patterns appear antithetical to our own values and vision? Here's why. It's taken more than a decade, but I now see Takeback Vermont, Make America Great communities as predictive of our global future rather than backwards. As we look across varied geographies, a perilous theme emerges. The feelings of dislocation and exclusion that are contributing to poor health outcomes here are also fueling a political agenda that threatens our efforts abroad. Scholars examining the apparent paradox of support from rural voters in rural Louisiana and Wisconsin for candidates who embrace positions seemingly at odds with their own health and economic interests reached a common conclusion. In each of these places, feelings of economic security and loss of status were contributing to what one termed a politics of resentment. Analysis of polling data from the 2016 presidential election finds support for a presidential campaign that's embodied this very politics of resentment to be especially great in areas with poor health and declining economic ability. In this discontent, we can trace eroding global support for the global cooperation that underpins our work with vulnerable communities abroad. This point was driven home to me personally when my work brought me to Greenland last year. As temperatures rise at twice the global average in the Arctic, Greenlandic communities are losing the sea ice on which their survival depends. As a way of life disappears with the melting ice, Greenlanders now confront an epidemic despair manifests in the world's highest rates of suicide and widespread substance abuse. The familiar pattern of devastation I saw weighed heavily on my mind as we went out to sea the last day of our trip. We were too far from where large icebergs were calving off from the ice sheet, but I could still see the remnants floating southward. Watching this, I was reminded of communities beyond the Arctic that are increasingly feeling the health effects of climate change, even as their access to healthcare improves. But then I recalled the ways in which inequities here are undermining the political support needed to counter this climate change. A mere 3 weeks earlier, the US had announced its intentions to withdraw from the Paris Climate Agreement, an accord seen by many scientists as our last great hope for arresting these changes. The imperative for equity became clear. Our failure to address inequities at home endangers our ability to confront global health challenges that know no boundaries of place or time. Global health, in its focus on dignity, offers a way to transform the social and economic anxieties that threaten communities everywhere into an agenda for change. The mere act of coming together to produce health requires us to see each other as human, to recognize we are not forward or backwards, urban or rural, deplorables or Democrats, local or global. Instead, it forces us to recognize we are not only individuals and communities with agency and aspirations for better lives, but also as citizens of a shared planet with a common future. And this is precisely the movement we need at a moment when what ails the body also ails the body politic. It's time to recognize that struggling American communities are the future of global health. And I believe that you, Dartmouth, have a unique opportunity to lead this bold health equity agenda beginning here in New Hampshire. Because we all know that what happens in New Hampshire matters, not just to this country, but to this world. And I know that your generation has the moral courage and imagination to confront the difficult questions that so many of us in global health have long ignored. So TEDx, Dartmouth, let us commit today to bring global health home for a healthier and more equitable future for everyone. Thank you.